Hi everyone, my name is Aditya Turi. I'm a second-year medical student at the Commonwealth Medical College, and today I'll be doing a basic science overview of obstructive and restrictive lung diseases. This is part of our MBS-MD small group learning activities, and hopefully it is just as useful as the arthritis lectures. So let's get started. So what are our learning goals for today? We want to basically review the relevant anatomy for the lung, obviously. We want to understand the different components of the respiratory tract and what their roles are in respiration. We want to understand some of the basic physiologic metrics that people use to describe some of these pathologic conditions. And these are all typically first-year objectives. You'll see this in your anatomy and histology course. You'll see some of this in the physiology course. And that's pretty much how you get a good understanding of normal. Next, we want to move on to understanding what diseases are characterized as obstructive lung diseases and what generally is known as an obstructive lung disease. We also want to do the same for restrictive lung disease. We want to know generally what is known as restrictive lung disease, and we want to talk quickly a little bit about the different restrictive lung diseases that we'll find. And we want to be able to compare and contrast the two. We want to understand how restrictive lung diseases present as opposed to obstructive lung diseases, and vice versa. And then quickly, we want to just go through the brief overview of the relevant pharmacological treatments. So it all starts with where air travels when we breathe. How does it get from the external environment down to our lungs? You'll see a lot of different books kind of approach this in various ways, but a lot of the physiology books that I've read and some of the lectures that we've done here really break it down nicely into a conducting zone and a respiratory zone. I think that this is the easiest way to understand this because it approaches the anatomy in a functional manner. So essentially we have the conducting zone, which is responsible for transporting the air from the outside to the inside of our body, but specifically there's no gas exchange with the conducting zone, and it's composed of components such as the nose, pharynx, larynx, and trachea. And these components are really important for how we humidify and warm our air as we breathe it in. And also specific areas like the nose have immune defense against some of the external pathogens that we would breathe in. The respiratory zone is characterized by the lung, which has bronchioles, alveolar ducts, and alveolar sacs. Understandably, this is where we experience a lot of the gas exchange. And the figure on the right basically depicts this. So you go from the nasal cavity to the pharynx, the larynx, the trachea, you get the main bronchi, and then you get bronchioles, and then eventually alveolar ducts, alveoli, and that's where you experience gas exchange. Important in our discussion today is just a quick discussion about the thorax. There is a lot going on this slide. I apologize. I don't think it's all that relevant for you at the moment. You'll get a lot more of this during your first year. I just want to go through some basic things such as the true ribs, the false ribs, and the floating ribs. Basically, you have 7 true ribs. Generally, people have some variance between them. Most people have 7 true ribs. Most people have 3 false ribs, and most people have 2 floating ribs. But basically the characterization here is based on the connection to the sternum. So the true ribs are directly connected to the sternum, whereas the false ribs, as you can see down here, these 3, are connected indirectly. And then finally the false ribs are not connected at all. This entire cavity moves up and down as you breathe. You can see the diaphragm outlined here. And you would imagine that your lungs would be somewhere in here. The reason I wanted to go through the thorax is because I think it's a really important part of potential issues regarding lung disease. We'll talk about that later towards when we get into the discussion of restrictive lung disease. But also it's really important, and David might get into some of this as far as just landmarks for auscultation. You really need to understand where these different bones are to understand how to auscultate and what you're actually listening for. So quickly just getting into the thorax, we want to look at the different components of the actual inside of the thorax. you have depicted here on this picture, you have the visceral pleura, which covers the lung, and then you have the parietal pleura, which lines the pleural cavity, essentially keeping us insulated from the rib cage. So between this is a very little, very negligible amount of space between the lung and the visceral pleura, and they basically slide against each other as the lung inflates and deflates. You can see here depicted on the left that there's a picture of a collapsed lung. Essentially, if there's any penetration from the external environment into the pleural space, the lung immediately collapses. Understandably, the opposite could also occur. So you could have a puncture between the lung and the pleural space, and that'll be known as a pleural effusion. So quickly just going through some of the lung anatomy. This is probably the first system where we've begun to talk about how you look at the patient. So you're looking at the anterior view here. So their right is technically on our left as we're looking at them. So the right lung has 3 different lobes. It has a superior lobe, has a middle lobe, has an inferior lobe. And you'll see that it's separated by these fissures, horizontal fissure, oblique fissure. The left lung, interestingly enough, has just 2 lobes. It's denoted here by the superior lobe, inferior lobe, and there's this little thing called the lingula, which is kind of looks a little bit like a tongue. And again, we just see the oblique fissure. The reason that there is not another lobe is because you got to remember the heart sits right here. So this is the left, this is where the heart sits. Excuse me. So now we're getting into the bronchi. As you come down, this is the trachea up here. You get down, you split into the 2 main bronchi, so the right bronchi and the left bronchi. Again, this is a busy slide. You don't necessarily need to know all these different branches and what they're called. You just need to have a general understanding that the bronchi eventually bifurcate into all these different branches. Specifically, an interesting fact here is that little kids, individuals who aspirate, they'll find that the objects or whatever comes down the airway typically goes down the right bronchi, and that's basically because of the way it angles. It's much easier for something to lodge down the right bronchus than it is down the left. So now we're getting down to the bronchioles and alveoli. You'll see that we have the 3 different types of bronchioles, the conducting, the terminal, and the respiratory, and then finally we get down to the duct, and then the sac, and then you have the surface of the lung down here. On the right here, we're talking a little bit about just some of the lymphatics. You can see it kind of surrounds all of these. You have the pulmonary artery, and then you have the bronchial artery. So looking at the histology, you guys are more of an expert on this stuff than I am, but we'll go through very quickly here just as a reminder. The conducting zone is really characterized by something that is known as respiratory epithelium, that's pseudostratified ciliated columnar cells, which ultimately progress down to cuboidal cells. Important to note here, you'll see that they're ciliated. This is basically so that if any material such as mucus or dust or particles get down there, the cilia can kind of beat them back all the way up into our mouth or into our nose so that we can kind of cough it up. You'll also see goblet cells in this area, and you'll see that there's cartilage, and these progress all the way till the end of the bronchi. And you'll also see smooth muscle. This is important because this is a really important intervention point pharmacologically for some of the diseases we're discussing today. Now moving on to the respiratory zone, we're looking at mostly cuboidal cells, and down by the alveoli, specifically in the type 1 pneumocytes, you're looking at simple squamous cells, and that's basically so that we can have good gas exchange. They're thin, and we need that to exchange gas efficiently. And also really important I want to mention here is the presence of macrophages. Specifically, they're known as dust cells. And they're extremely important in all the different types of particles we end up inhaling. If something gets all the way down to the respiratory zone, um, macrophages can basically engulf them and take care of it. So now we're getting into the Alveoli histology, beginning with the type 1 pneumocytes. We mentioned these a second ago. Basically, they're squamous cells. They're thin, which allows us to have gas exchange. Moving on to the type 2 pneumocytes, they're cuboidal. Importantly, they secrete surfactant. Surfactant allows us to decrease the surface tension found within alveoli, which prevents them from collapsing. Next, type 2 pneumocytes serve as our stem cells in the alveoli, so basically they also serve as precursors to type 1 pneumocytes. Clara cells are also found in alveoli that are non-ciliated, low columnar to cuboidal cells with secretory granules. And basically the secretory granules provide us with some immunoglobulin to protect us against pathogens. So quickly just looking at some of the histology, we see here the respiratory epithelium. You see the pseudostratified nature of it. You see the cilia on top. You see the presence of a goblet cell here. You might see some glands, and there's connective tissue. Interestingly enough, there's smooth muscle here, and that's kind of a big deal for what we're talking about today. Moving on to bronchioles, it's a lot of the same type of stuff. You can also see some smooth muscle here, but interestingly enough, you also notice some lung parenchyma. This is how you kind of know that you're in the lung. And again, you see the epithelial cells which line the lumen. Now looking at the alveolar ducts and sac, you see the respiratory bronchiole branching off into a duct, which then eventually gets down to the individual sacs and then the individual alveoli themselves. Looking quickly at the pneumocytes, here are the type 1 pneumocytes, here are the type 2 pneumocytes, and here are the capillaries kind of dispersed throughout the alveoli wall. So now we're getting into some of the physiologic metrics that clinicians will regularly look at when looking at patients with respiratory diseases. It also gives us some basic understanding of how the lung functions, and these values really do come in handy when looking at the different disease processes. So the inspiratory reserve volume is basically air that's breathed in after normal inspiration. So basically, after you take a breath, there's still a certain amount of air that you can continue to breathe in. Next, moving on to tidal volume, this is basically the air that's moving out with each of our quiet inspirations, and it's typically 500 milliliters. Moving on to the expiratory reserve volume, this is essentially the air that can be breathed out after normal expiration. So you take a normal expiration and then you still can expire some more. That is what the expiratory reserve volume basically looks at. Then the residual volume is essentially what's left. So it's the air that kind of stays in the lung after you've breathed out everything you can force out of your lungs. And importantly, it can't be measured on something known as spirometry, which is basically a way to measure some of these values. Some other values here: inspiratory capacity, functional residual capacity, vital capacity, and total lung capacity. Total lung capacity is an important value for us to consider today. The vital capacity is also important for us to consider, but these are values that can essentially be derived from some of these other values. So this is something that David hopefully will get a little bit more into with you, but I want to bring it up today because it's important for how we distinguish these diseases pathologically from one another, and it allows us to basically understand what we're dealing with. So we have our forced expiratory volume in the first second. Basically, how much air do you breathe out in the first second? And then the next value here is forced vital capacity, and that's basically the air that you breathe out in one full breath, as hard as you can. So looking at the normal lung, you'll see that we have lung volume on the left here, and then we have time down on the x-axis, and you'll see that we start off with a volume somewhere above 6, and in the first second you breathe out almost about 5 or so liters, and then you continue down to as much as you can breathe out, and that's 2 seconds, and then you quickly kind of come back up. Now we look at these two values as a ratio because that's really helpful in distinguishing the differences between obstructive and restrictive diseases. We'll get into obstructive and restrictive specifically as we move forward, but we'll start with obstructive. So we have the forced expiratory volume and we have the forced vital capacity, and you'll see that it's less than 70%, which is less than normal. So there is a decrease in the ratio in obstructive diseases. So looking at obstructive lung diseases, they are a category of respiratory diseases characterized by airway obstruction. That is super, super important. Air is basically trapped in the lung and does not empty appropriately. You might hear the term COPD, chronic obstructive pulmonary disease. That's basically what we're talking about here with obstructive lung diseases. There's a litany of different diseases that fall under obstructive lung diseases. Some that we'll consider today are chronic bronchitis, emphysema, asthma, and bronchiectasis. So looking at the values that we just spoke about, FVC is decreased in these patients, but more interestingly, FV1 is really decreased in these patients. So it's significantly decreased compared to FVC, and then therefore our ratio is decreased. Do you understand why? It's basically because our numerator decreased by a greater amount than our denominator, so that our total ratio here decreases. So going on to our first disease here, what is chronic bronchitis? It is basically a condition characterized by hyperplasia of mucus secreting glands in the bronchi. And you'll hear the term blue bloaters kind of thrown around by clinicians and probably second-year medical students and people who read a lot of first aid. But basically it's essentially the easy way for us to remember that these patients are cyanotic. They look like they have a lot of trouble breathing. We had a pulmonologist come in and describe chronic bronchitis as, take a breath all the way in and just let a little bit out at a time, and then take another breath in all the way in, and then let a little bit out. It's really, really tough, and these patients essentially become cyanotic. They have decreased PaO2, and then they have an increased PaCO2 because they can't get rid of the CO2 that's kind of building up in their lungs. This disease is clinically diagnosed in that it's a productive cough that lasts for greater than 3 months over a minimum of 2 years. Now, it's important to note that this productive cough does not need to be continuous. These patients present with an increased risk of infection and something known as cor pulmonale. Cor pulmonale is basically a condition where our lungs are really, really smart. They like to shunt blood away from areas of the lung that are diseased. Cor pulmonale is basically a perversion of this concept, where the lung believes that this area, a certain area, is unable to ventilate properly, so it pushes blood somewhere else, but that area is also unable to ventilate properly, so it pushes it somewhere else, and that area is unable to ventilate properly. So basically the lung just shuts down, more or less. And that's a really serious condition because at that point we're not ventilating at all. And these patients will be in serious distress. This condition is highly associated with smoking. It is big time found in smokers. You'll find that a lot of these obstructive disorders are found in smokers. Point of the story, don't smoke. So this is kind of what it looks like. We said it was a hyperplasia of mucus glands. This is where you start to see a lot of mucus glands. This is, one over here, and then there's like a line of them that goes all the way down. This is not normal. You should see a handful of these, not necessarily as many as we're seeing here. So I want to just quickly take a sidestep here. You guys haven't had any formal pathology courses, and I just introduced a term that I think is really important to go over. And this will be helpful as we go through other systems, and specifically as you get into medical school in the second year. This is something that kind of dominates the discussion a little bit. So this is just a basic schematic here of two cells. When we talk about hyperplasia, this is a condition where we're essentially multiplying the number of cells. So there's now 4 cells over here. Contrasting that with something that's known as metaplasia is when the cell itself changes types. You'll see this in the esophagus with patients with GERD, which is essentially an esophageal irritation due to stomach acid kind of popping back up. You'll have a change in your cell type from one cell to another, denoted here by the red. So this is not the same cell type as this. So you might have something that's squamous going to columnar, or you might have something that's columnar going to squamous. So it's really what characterizes metaplasia. Next, moving down to hypertrophy. Hypertrophy is basically when our cells just get larger. You'll notice that there are certain places in our body where we experience hypertrophy naturally. What are we doing when we lift weights? Our muscles are undergoing hypertrophy. They're not multiplying, but they're just getting bigger. And that's an important thing to understand too. They're not more cells, they're just getting bigger. Next, and finally, we look at something like atrophy. Atrophy is a pretty simple concept. We are losing cells. And so denoted here by 2 initially, down to 1. So these are basically really important principles because you'll start to see discussions about cancer, discussions about tumors, discussions about pathological processes that take into account each of these. So you'll see hyperplasia in obstructive lung diseases with chronic bronchitis. You'll see metaplasia in things like cancer. You'll see hypertrophy in cardiac conditions. Cardiac hypertrophy is it's not a good sign, and atrophy, which is basically just kind of wasting away. All right, back to our lung diseases here. So what is emphysema? Emphysema is one of those things that I got to medical school and I heard the term so many times. You'll see all the commercials on TV about people with emphysema, but essentially it's a simple concept in that it's a destruction of the alveolar sacs, and it's basically due to a loss of elasticity, which cause the airways to collapse. Naturally, our airways have some elasticity, which allow them to kind of stay rigid and open. But if we lose that elasticity, those airways have to collapse. And that ultimately leads to trapping of air. Again, we see the concept of trapping of air. This occurs through 2 different mechanisms. And I want to emphasize here, and David will probably talk about this a little bit more, is so in chronic bronchitis, we saw that it was highly associated with smoking. Emphysema is also highly associated with smoking, but these patients can also be non-smokers, and you'll kind of scratch your head and wonder how did they get emphysema if they didn't smoke, and it's because of the second mechanism here. So quickly, let's go through the first one, and then we'll talk about why the second one is so different. So you have basically chronic inflammation through smoking. Smoking has tons of irritants that basically trigger your immune system to start creating an inflammatory process in your alveoli. So you get this chronic inflammation over time. It's basically just little amounts of damage to your lung. over and over and over again. Patients with something known as alpha-1 antitrypsin deficiency lack a defense against some of the proteases that we experience in inflammation. Our lungs are constantly being bombarded with particles that shouldn't be there. It's just the way that the air is. I would argue that in some cities it's probably a lot worse, like Houston. Houston has one of the worst air pollution records in recent memory. But basically, our body produces alpha-1 antitrypsin, which allows us to inactivate some of the proteases that are associated with some of just the regular inflammation that our lungs see. So these patients aren't necessarily smoking. They're just walking around breathing normally like everyone else. But the issue is that they lack the ability to kind of degrade some of the inflammatory components. And so they just basically get the chronic inflammation that's normally seen in smoking, but now they're getting it because they lack a specific enzyme. And that's more genetic. So this is what emphysema looks like. You'll see that there's kind of consolidation of alveoli. What was typically a picture of alveoli on histology is you see like a lot of little sacs. What begins to happen is a lot of those sacs begin to coalesce into one giant sac. This really, really hurts us in terms of how much we can kind of exchange, because the amount of sacs increases the amount of surface area that we cover, which ultimately increases the amount of exchange that we can partake in through our capillaries. So how do these patients typically present? In contrast to the chronic bronchitis patients, these patients are known as pink puffers, and that's basically because they have a prolonged expiration. They just can't get the air out of their lungs. So essentially, they purse their lips, and they have to kind of give some more effort, so they turn red or pink, and that's why we call them pink puffers. You'll also see that they present with something known as dyspnea and cough. So basically they have trouble breathing, and that there's minimal sputum. And that's really important to distinguish, because things like pneumonia and other things can present with dyspnea and cough, but they'll typically have some sputum. Chronic bronchitis has a ton of sputum. These people are coughing up buckets of sputum. So it's important for us to understand that they have minimal sputum and it's dyspnea and cough. They have weight loss, and they also have something that's known as an increased AP diameter, which is basically their chest wall is it looks like a barrel. So we'll call them barrel chested, and it's basically just all the air that's trapped inside their lungs. They also present with something known as hypoxemia, and again we see the possibility of poor pulmonary. Hypoxemia is basically just the fact that they don't have enough oxygen diffusing through. So what is asthma? So asthma is a condition that's characterized by reversible airway bronchoconstriction. The others that we had discussed previous to this just now, emphysema and chronic bronchitis, unfortunately they're not really reversible. They're kind of constant, and these patients are usually kind of on their way out. Asthma, as you kind of understand, is kids have it. I mean, they take an inhaler and they're fine. And that's because it's reversible. And it's often due to allergic stimuli. And going back to one of our favorite topics here, is it's a hypersensitivity. It's a type 1 hypersensitivity. So quickly, what cytokines are important in type 1 hypersensitivities in general, but specifically here with asthma? I'll give you a couple of seconds here. All right, so basically we have IL-4, which allows us to class switch to IgE. We have IL-5, which allows us to attract eosinophils. And then we have IL-10, which allows us to kind of maintain this process by stimulating the development of Th2 cells. These are all big components of an allergic response: IgE, eosinophils, Th2 cells. And interestingly enough, IL-10 inhibits Th1 cells. So we're perpetuating our ability to generate an allergic response. And this is due to some sort of stimulus. Something is triggering this condition. So patients with asthma typically present with dyspnea and wheezing, and they also present with tachypnea, which is rapid breathing. They have a productive cough with something known as Kirschmann spirals. So Kirschmann spirals are basically whorled mucus plugs, and they are basically shed epithelium. They also present with something known as eosinophil-derived crystals, which are called Charcot-Leyden crystals. This is way more important during medical school. It's not something to get bogged down with right now. They also present with something known as pulsus paradoxus. So basically, when we breathe, normally there is a drop in our systolic pressure. That's normal. However, normal is defined by a drop in 10 from our normal systolic pressure. Anything more than that is characterized as pulsus paradoxus. Pulsus paradoxus is really important clinically because it helps us pick up on respiratory diseases. And then there's also mucus plugging with patients with asthma. Okay, finally, what is bronchiectasis? It is essentially a permanently dilated airway, and it's usually due to necrotizing inflammation, and that can occur through a lot of different mechanisms. Cartagner syndrome, you may have spoken about this during genetics. It's essentially a defect in the ability of cilia to function, and these patients will present with some really unique findings. They have sterility issues, they have issues with chronic respiratory infections, and they have situs inversus as well. So you can understand that they would have issues with necrotizing inflammation because they cannot clear the pathogens that get into their system. Patients with cystic fibrosis understandably have necrotizing inflammation. Allergic bronchopulmonary aspergillosis is a really long name for you have an incredibly allergic response to aspergillus, which is a fungus found in soil. Tumors can obviously provide a source of necrotizing inflammation. And finally, the obvious, necrotizing infection can cause this permanent dilation. And these patients will also present with cough and dyspnea, but they also have this foul-smelling sputum characteristic that kind of helps us distinguish them from the others. So again, looking at our pulmonary function test, we just reviewed obstructive. We have a decrease in the amount that they can blow out in the first second, and an overall decrease in the amount that they can blow out totally. But overall, we have a decrease in our ratio. Now moving on to restrictive diseases, we're going to see an increase in that ratio, and we'll talk about why. But basically, they have a decrease in the FEV1, but they have a much greater decrease in the FVC. So restrictive lung diseases are characterized by the decreased ability to fill the lung. They have a decreased FEV1, and they have a really decreased FVC. And that's basically manifesting in an increase in the ratio because our denominator is decreasing by a greater magnitude than our numerator. These diseases are typically due to interstitial diseases or chest wall abnormalities. Basically, it's issues with the actual tissue or issues outside of the tissue. Excuse me. So we're not going to get into an in-depth discussion about restrictive diseases because there are a ton of different diseases that can cause this. I just want to talk about some of them just so you have them in your mind, and we can have a bigger discussion about these during the small groups themselves. But you'll see something known as idiopathic pulmonary fibrosis. Basically, these patients just have fibrosis in their lungs, bilateral fibrosis on their lungs on CTs and X-rays, and there's no reason why. They just have fibrosis over the years. Pneumococces are basically, again, issues with fibrosis, but it's due to exposure from a specific substance. So coal workers, pneumococces is essentially due to the work in mines and all the different dust and particles that they would inhale during that time. Silicosis, exposure to silica. Interestingly enough, you'll see this with a specific profession known as sandblasting. I didn't even know that existed until this year, but basically it's the blasting of walls, of external walls in buildings to kind of wash them with sand. Then you'll also have berylosis, which is exposure to beryllium, and asbestosis, which is the obvious exposure to asbestos. Sarcoidosis, which is one of those board favorite questions that I don't know is that particularly prevalent in the general population, is essentially something that presents very similarly to berylosis. It's a non-caseating granulomatous disease seen in the lungs, but it also presents with granulomas elsewhere in the body. Acute respiratory distress syndrome is something that you will see in ICUs and throughout your time in medicine. It's basically our inability to diffuse oxygen appropriately due to chronic inflammation causing deposition of hyaline on the alveolar surfaces. So it's an extra layer that air has to kind of go through before we can perform gas exchange. Neonates have a version of that, neonatal respiratory distress syndrome. Goodpasture syndrome is an autoimmune disorder. You can see some drugs. Bleomycin is classically seen as providing lung toxicity. And then there's also Wegener's granulomatosis, which is a specific type of granulomatosis that presents with polyarthritis. So going back to our pulmonary function test, again, decrease FEV1, much greater decrease in FVC, therefore an increase in our ratio, the drug theophylline. Leukotriene modifiers. Leukotrienes really mediate some of the bronchoconstriction we'll see. So drugs like montelukast and xylitol. Xylitol basically decreases the amount of leukotrienes that we can synthesize, whereas montelukast is essentially a receptor antagonist, so that whatever leukotrienes we can produce don't necessarily create a response. I like to think of xylitol as very similar to, it's like aspirin but for leukotrienes. So you would normally inhibit COX in aspirin or NSAIDs, and xylitol you're inhibiting 5-LO, which is a similar enzyme. So I know that this was a really long lecture. I apologize. It's a very broad topic. We really skimmed the surface here. You're going to learn a lot more in medical school, and these two categories of diseases are really, really prevalent, and you'll see a lot of it in the clinic. So having a good grasp on them is important, and hopefully us taking the time today gets you a step closer to that. David will do the clinical lectures for this, so hopefully you'll gain more out of that. I hope that you were able to get a basic understanding of some of the basic science that goes into this, and be primed to do well in the clinic. All right, thanks guys.